So thank you everybody. I'm gonna talk to you today about how to do a ultrasound of the abdomen and the chest. Efast focus assessment of sonography for trauma extended, because we're gonna talk about the pleura and the lung as well. This is a machine that we use for it. We're gonna use the phase array probe, which is a square probe that has a depth of a frequency of about 5 to 1 megahertz. This allows me to have more penetration and less definition. This is usually used for the heart, but you can do lung, pleura, abdomen, everything with this probe. Now, if you don't have that probe, then you might have this curvilinear probe, which is also a frequency between 5 to 2, and these allows for good penetration, and it curves nicely in the abdomen. However, it's not great for the chest or for the heart, and it has less crystals, so the image will be less sharp when you save it. For the lung and the pleura, you can also use a higher frequency probe. This higher frequency probe is great for vessels, for neck, for thyroid. It has a frequency between 13 to 6 megahertz, and it has less penetration but more definition, especially in the superficial areas. I'm going to do it fast, like I usually do it with this probe, and I do it with this probe because I don't have to change probes, and it allows me to be fast doing the fast, rapid doing the fast. The first window that I do is the subxiphoid. Why? Because not all machines are made the same, and if you look inside of the heart, then an alive patient, that will be blood. If you look inside the heart and you know how that looks like, then you can identify how blood is going to look inside of the patient's abdomen. So you know that each machine has a different grayscale. We have great machines now everywhere. However, in some underserved areas where I have taught before, the machine might not be great, and you might be working with less resources. So that is why, for me, that's the most useful window. It also allows me to see immediately if the patient is hypovolemic or not. So then I can change the speed in the way that I do things when I'm treating the actual patient. The main mistake that I see when subxiphoid is done is that people go straight. That's not the right way to do it. You will have a great view of the aorta, that's it, and the spine, maybe if you're lucky. You want the probe to go under the ribs and look up to the heart. And this is how we're going to do it. All right. So in order for you to know that there's no effusion, you have to see the entire heart. Blood will go where the gravity goes, so it goes posterior. If you see half of the heart, you cannot say that this patient does not have an effusion. You need to see the entire heart. And in this window, we see the liver, we see the right ventricle, left ventricle, the atria. Take a deep breath for me. And when he takes a deep breath, we see even better. And then the probe was flat. We're going to turn the notch superiorly so we can have a great view of the vena cava. And that's the vena cava with the hepatic veins going into it. And it's a normal full vena cava because this patient is hydrated. I'm going to move then the probe to the right upper quadrant position. In the right upper quadrant, this is a beautiful view of the diaphragm, the liver. I'm going to get you a better view of the kidney. If we had blood, it will show right here in between the kidney and the liver. This is the first place where the blood goes when you're doing a fast, because it's the more dependent place. Now, this view also gives you another great information. If I see nothing above the diaphragm, it means that it's a normal lung. If I see lung bathing into blood, that's a hemothorax, but he has no hemothorax. And if you move it a little bit more posterior, you should be able to see the vena cava here as well. That's the posterior view of the vena cava, and then you can move it a little bit more anterior and see the kidney again. Now I am going to go to the left upper quadrant. Now this one is a little bit more technically challenging, especially for people like me that are short and have small hands and small arms, because it's more usually I'm in this side of the patient and I'm reaching, and the spleen is higher than the liver. So you go in the same place where you go, but a little bit higher, and this is the spleen right here, the kidney right here, which is normal, And the very shiny structure that is hugging the spleen right here is the diaphragm, and above the lung that looks like nothing. It should look less like nothing because air is a very poor conductor of ultrasound. If you're going to have a pneumothorax or a hemothorax, the hemothorax will look like blood or fluid bathing the lung. The pneumothorax is just artifacts, and we'll talk about it in a minute. So that's your spleen, your kidney, and blood here accumulates in between the kidney and the spleen, and also above the spleen. So you have to see all the spleen to be able to see that it's negative. And I see his spleen is pretty small because he has a normal spleen, and he's negative. There's no blood. And then I'm going to go to a bladder. And in order to see the bladder, we're going to go pointing down. And there it is. This black structure, or hypoechoic, because it's full of urine, is not, you can see that there's something here, it's a little shiny behind it, that's called posterior enhancement. The ultrasound waves are going super fast because fluid is a very good conductor of sound, so therefore this is going to look shinier. These can hide fluid as well, so you want to have two views, with the probe flat, horizontally and vertically, to make sure you have two views of the bladder and you're not neglecting fluid around it. As you can see, there's posterior enhancement, shiny, it's very shiny behind it. Okay, so I'm done seeing, and he doesn't have any blood in the chest, in the abdomen, or the pelvis. And then I'm gonna take a look for the pleura. This has a lot of penetration, but with these machines, most of these machines, you can decrease the depth enough that you can see the pleura. And this is what we're going to do. We're going to make it very, very, very superficial until we cannot do it anymore. Take a deep breath. This is what is called the bat sign. If you imagine, this is the wing of the bat, and the head. Where the head goes, there's a shiny structure that is very, very shiny and moving when he breathes. That's the pleura. These lines coming vertically are called B lines. These lines coming horizontally, they're coming A lines. If you have a pneumothorax, you won't have B lines, but you see a bunch of B lines. And I'm gonna show you more. If you put it in M mode, which is movement mode, it's part of B mode, you can see it looks like a C and a shore. Seashore sign means no pneumothorax. If he had only C and no shore, then it will be a pneumothorax. So normal, no pneumothorax, and then let me take a look again here. Make sure that's the advantage of the human being, is that you have two things of everything. You have two chests, so you can compare. And here we go. The bat sign with the bat sign is basically just the shadows of the ribs, because the ribs are so shiny, bone reflects everything, and no ultrasound wave passes through. And then again, I see the B lines coming down, the pleura moving very nicely, which is lung sliding. Is a sign that there's nothing in between. And then I'm going to go to M mode and press it again, and we have our C shore sign. Means he does not have a pneumothorax. And you can do this with the linear probe as well, which we have here very conveniently, and I'm going to show you that there's a little bit of a difference, but not a huge difference. If you do it with the phase airway probe that I just did, it will be fast. You have a view of the heart, the abdomen, and the chest. You can do it with this high frequency probe, and it gives you a little bit more resolution. You can see the B lines a little bit more obvious. This is the pleura, this is the bat sign. The ribs are producing your shadows. Very, 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 very shiny pleura. And these B lines, they're obvious. When you're in the ICU and you put the probe in the chest, you see a huge heart and you're not sure if this patient is overloaded, take a look at the pleura. If the pleura has a lot of B lines, this patient has fluid overload. And let's do the M mode, and you press it again, and the C shore sign. No pneumothorax. If it was a pneumothorax, it would look like this, only C. Then we go to the other side, and again, beautiful pleura. Take a deep breath. You can see how the pleura moves. It's really, really shiny. B lines are the ones, again, that come from the pleura down. A lines are the ones that come horizontally. We're going to do our M mode. And you have to be very careful when you put your cursor in the M mode. Put it in the pleura, because obviously you have a false positive. And that's our seashore sign. Beautiful. Really good. And that was a very short version of what extended fast should be. It is very useful to look for pneumothorax, for hemothorax, for blood in the abdomen, to look at the heart with that view only. You can look for contractility, effusion, and volume. Is the basics of what any surgeon or provider that is taking care of critically ill patients, trauma or emergency surgery should know about ultrasound. Thank you so much for your time.